The presentation is on Medicare basics and updates for 2025. Before we get started, I do want to share a little bit about VLP and who we are. There we go. So we are a financial planning and wealth management firm. We're located in Vienna, Virginia, but we work with clients nationwide. Our goal is to be a trusted partner to the individuals, the families, and the businesses that we serve. In the last 25 years, we've grown from a 2-person firm to a team of 20, which includes 7 financial planners, certified financial planners, 4 accredited investment fiduciaries, and 2 certified financial analysts and a divorced financial analyst. Today, our advisors have a collective experience of well over 100 years. Even as we've grown, what sets us apart is our culture and our team approach to financial planning. Our motto is to work together to dream big, plan smart, and take action. For those of you that are joining for the first time today, we want to welcome you and let you know that we offer these complimentary webinars once a month on a wide range of financial planning topics and investment topics. We find education to be an important aspect of the planning process, and so we're excited to host and share these various topics and experts. And also, just these webinars are not just for clients. You're always welcome to pass the link along to anyone that you know that might benefit from the information. So just a few quick housekeeping items before we get started. Just be sure to keep your lines muted and your videos off to minimize the background noise and other distractions. For questions, there will be a couple of pauses in the presentation. That would be a great time to ask those questions. Also, feel free to type your questions in the chat box as you think of them. And then you may unmute your line and ask your questions during those short presentation breaks. I'm going to introduce our speaker, Emily O'Halloran. Emily is the Executive Director at Medicare Portal. She's the leader in Medicare education and enrollment services in the Mid-Atlantic region. She's licensed in 21 states plus DC. Emily's helped hundreds of individual Medicare beneficiaries navigate the often bewildering Medicare enrollment process. She's guided clients in plan selection, benefit utilization, management of Medicare impacts from life changes, understanding and appealing Medicare income-related charges, and anything else that helps her clients' Medicare experience. She's a regular speaker on Medicare education topics to community groups, financial advisors, and their clients' retirement communities, and more. Prior to Medicare, Emily's professional background is in training and curriculum development, and she draws on that experience to amplify Medicare education wherever she can. All right, at this time, I'll turn it over to you, Emily, so please go ahead.
Thanks so much, Sarah, and it's great to be back here again this year for some Medicare basics refresher and some of the most important things that we'll want to touch on as we begin the Medicare annual enrollment period, which just started technically yesterday, and we'll touch on that a little bit more in just a moment. All right, so as Sarah said, as a larger team, we are MP Group, and while based in Tyson's Corner, we serve over 40 states now, and my team and I serve 21 states and DC. So I'm very concentrated on Mid-Atlantic, East Coast, and Southeast, but through my colleagues that I work closely with, we can refer folks from over 40 states now. And our main emphasis is on Medicare education. As Sarah said, my background is in training, and we really just feel like Medicare is something that you cannot learn enough about. There's always something changing, and it's its own entity that tends to remain a little bit confusing even for people who are Medicare eligible and on Medicare. So our emphasis is education first and foremost, and that's why we love opportunities like today where we can talk to folks and hopefully provide some clarity on some of the things that you hear and read about Medicare. And we also assist with Medicare enrollment, plan selection, and then support over the years as those plans change or as life changes and you need to make adjustments to those plans. So we always say no more and stress less with MP Group. I do think that the secret to your best Medicare experience is going to be in understanding Medicare better and by being here today, you're taking a step in that direction. So great job, everyone. So this is just a little map to show you our current 40 states that we serve, and we tend to continue to grow this service area all the time. All right, so what we are going to cover today, we're going to do a quick review of some basics, starting with the parts of Medicare, what they are, and then not a part of Medicare, but integral, especially for a lot of folks who have these plans, will be the Medigap plans, and we'll touch on what Medigap plans are. Then we'll talk about the difference in Medicare coverage through a Medicare Advantage plan versus original Medicare, perhaps with a Medigap. So those are your two main styles of Medicare coverage that you can have, and we'll compare and contrast those two. Next, we'll touch briefly on the two most common Medicare enrollment periods. While I recognize that some folks who have joined us today are already enrolled in Medicare, you may be here with Medicare on the horizon, approaching soon perhaps. And so we'll touch on these two enrollment periods and what you need to know. Next, we'll talk about Medicare Part D, which does tend to be the most confusing part of Medicare. So we'll look at how to understand it a bit better, especially with a very significant change that is coming for 2025 that you may have heard about in the news, especially with an election year occurring. We'll talk about that, why it's happening, what it means for you if you are currently on Medicare Part D. And then finally, we'll end with talking about this Medicare annual enrollment period that we're starting in right now. And we'll talk about those of you who are currently on Medicare, what your options are and what they're not for this enrollment period, and the things that you need to be looking for so that you're best prepared for making any plan changes if you need to make those. Okay, so let's do a review of some of these basics on the parts of Medicare. So the first two parts of Medicare, where it all started about 60 years ago, is with Medicare Parts A and B. Now, these two parts of Medicare together make up what is referred to by Social Security as Original Medicare. A and B are strictly from the federal government. So there is no private insurance offering Medicare Part A and Part B. This is what the federal government offers, Original Medicare. Part A has the name hospital insurance, and that is true. It will cover your inpatient hospital stays, but it will also cover stays in skilled nursing facilities, and it will also cover home care and hospice. So Part A, we like to think of that more as inpatient or admitted care. It can be a little bit confusing with the name hospital because every time you go to the hospital, it doesn't necessarily mean that that's a Part A service. Part B, on the other hand, is named medical insurance. So Part A is Medicare hospital insurance and Part B is Medicare medical insurance. Well, a better way to understand Part B is that that is your outpatient care. So this outpatient care will include office visits with primary care and specialists. It will include urgent care, ER, outpatient surgery, radiology, labs, medical equipment, preventive care. Some of those things I just mentioned may happen at the hospital, but they'll still be Part B Medicare services. So A is inpatient and B is outpatient. Now, most Americans will have earned their premium free, so in other words, $0 per month, Part A, when they have reached 65. So that is earned after 10 years or 40 quarters of work history, and that can be through a spouse. So for folks who have stayed home, you can be eligible for premium free Part A through a spouse. So most folks will have no monthly premium for Part A, and then Part B does have a monthly premium. What most individuals will pay is the base premium, which is actually 25% of the true cost of Part B, and Medicare itself is paying that other 75%. But there are a lot of people, especially in our region, who will have a higher than average income and who will pay more than the base premium for Part B. So instead of paying 25% of the total cost of Part B, where Medicare is paying the other 75, people who have a higher than average income, even well into retirement, because this is something that's checked every year, those individuals may pay 35% of the cost of Part B, or 50, or 65, or 80, or even 85%. So there are income adjustments on the monthly cost of Part B. Okay, so those are your first two parts of Medicare, true parts of Medicare. And then the next two are parts C and D. And both of these parts of Medicare are offered by private insurance companies who contract with Original Medicare. So Part C is the official name of the Medicare Advantage side of Medicare. And we'll talk a little bit more about what that means, what Medicare Advantage plans are. But Part C is the Medicare Advantage side. And in a nutshell, these plans combine your A and B benefits, and they usually also bundle in your Part D benefits. So they're sort of an all-in-one package where all of your benefits come through one private insurance company. And then finally, Part D. These plans, again, are offered by private insurance companies that contract with Medicare, and they are standalone plans when they are not part of a Part C plan. So Part D standalone plans will offer just Medicare prescription drug coverage. So these are your four parts of Medicare. Now, one of the things that becomes confusing is when we start talking about Medigap plans. Medigap plans are Medicare supplement plans. Medicare supplement is what they're really called. Medigap is kind of a slang. And these plans also have letter names. So thanks a lot, Medicare, for giving us parts A through D, and then deciding to use another word that starts with P, plan, and more letters for the Medigaps. So these are completely different things, but we've just happened to make them more confusing by using the word plan separate from the word part and using more letters. We could have gone with choice 1 through 13 or something, but we're at plan. So these are plans that are offered through private insurance companies. They are not contracted directly with Medicare, but Medicare does have some oversight and provides guidelines for these plans. They are secondary to only Medicare A and B. So one analogy that makes sense for most people is if you remember Lego blocks, or if you have, kids or grandkids that love Legos, and you think of the chunky Lego block with the two dots on it, if that's your A and B, then there's going to be a flat Lego block that locks into it, and that's your Medicare supplement. It is a secondary payer, just completing your A and B coverage by paying after A and B pay, picking up the Medicare members' cost-sharing amounts so that those don't come to you. So it's covering the gaps in Medicare, hence the term Medigap. Now, again, all of the benefits are standardized by Medicare, and those premiums will vary from company to company. They also vary from state to state, and there can be very drastic differences in the cost of Medigap coverage from one state to the next. You also see differences in what you pay for these based on gender, age, tobacco use, and so on. But that is what a Medigap plan is. And now let's talk a little bit more about what it's like to actually have either a Medicare Advantage plan or Original Medicare with a Medigap or Medicare supplement plan. All right, so the more conventional option is to have Original Medicare, so that's A and B, which is on that red, white, and blue card, and to have that as your primary insurance. Now, as your primary insurance, it's your first payer of all your claims. It's who your healthcare providers are submitting their claims to. And then from there, you would add this Medicare supplement insurance plan or your Medigap plan as the secondary payer. So they are going to pick up those out-of-pocket expenses that would otherwise be coming to you. This is really important because all of the out-of-pocket expenses after Medicare A and B pay are completely unlimited. So there are no out-of-pocket maximums, no caps on Medicare out-of-pocket, either annually or for your lifetime. On the good side, we see really enormous amounts that Medicare will pay for our care. But if we have a 20% coinsurance that we're responsible for to go along with those enormous healthcare costs, we don't want to be the one paying the 20%. We want to have a Medicare supplement or Medigap plan that's there to pay that amount. So it's really about the unknown and the potential for extremely high healthcare costs and having that unknown covered, that unlimited amount covered by a Medicare supplement. Now remember, the Medicare supplements only lock in like those two Legos on A and B. A and B are 60 years old, and they were started before Medicare prescription drug coverage was added to the Medicare law. So when Part D was added several decades later, for those who choose to have Medicare A and B as their primary insurance, a Medicare Part D plan is like an a la carte selection. It's a separate add-on and it doesn't really interact with A and B or your supplement. It's just its own separate piece of coverage. And there are a lot of Part D plans offered, but we'll talk about some of the changes in Part D in a few minutes. Now, the alternative to all of this is also a newer part of Medicare. Remember that Medicare Advantage plans are the Part C part of Medicare. And these plans are an option that allow a Medicare member to be enrolled in A and B. And remember, for most of us, there won't be a premium for Part A, but there will be a monthly premium for Part B. And if you have A and B and you continue to pay the premium for Part B, you can choose to enroll in a Part C plan. You're going to keep paying for Part B, but put away that card. And now all of your benefits would be coordinated through a Medicare Advantage or Part C plan, one card offered by a private insurance company. It will cover all of your Medicare hospital benefits and medical benefits. Also, typically, your prescription drugs will be bundled in under that same card. And these are the plans that offer the extras that you hear about. So the typical extras, the baseline extras, are going to be basic dental care, basic vision, and hearing. There will be others that you'll hear about, things like fitness or personal emergency response um, um, systems. There will be many other things that you'll see, but the key additional benefits are typically going to be dental, basic vision, and hearing. Now, all of those items are often included in these plans because they were not included with original Medicare A and B. If you think about life 60 years ago, it kind of makes sense. We don't feel the same way anymore. I think we all know that our dental health, our ability to see well, and our ability to hear well are all integral to our overall health. But 60 years ago, when the law was written for Medicare A and B, they did fall into the want, not a need category. And so that's why they are not a part of original Medicare. All right, so let's put these two types of coverage side by side and talk about the differences in them in a few other ways. Now, some of these things we've already touched on, starting with who is paying your claims. Well, when you have original Medicare A and B, and then you have that Medicare supplement or Medigap plan as the secondary payer, that secondary payer pays after Medicare A and B. So your first payer is literally the federal government, and then the secondary payer is that private insurance company paying instead of you, which is nice when it's you. On the Medicare Advantage side, while you are still paying the monthly cost of Part B, either paying it directly to Medicare or having it come out of your Social Security benefit, when you enroll in the Advantage plan, you keep paying that. You may have a small monthly premium for the Advantage plan, but now this plan has basically taken over your care on behalf of Medicare, and they are your primary and only payer for your claims. Shouldn't say only, because if you go outside of this plan, then you would be the payer for your claims if it's something that cannot be billed to your plan. So they are replacing Medicare, and they are doing this using a fixed monthly amount that Medicare is paying to this Advantage plan. And for a little bit of background on this, if you want to sort of think big picture at why this might happen, the concept is really that with our population moving in a direction where more and more people are on Medicare, and increasingly more than we're seeing in the workforce, to replace those who are going on Medicare, we are going to have just more Medicare expenses every year. And then that's not even talking about how healthcare costs increase every year, even more than regular inflation. So we have all of these people on Medicare, all of this Medicare spending, when the federal government can pay a private company a fixed monthly amount. It's intended to sort of level out those Medicare costs, the cost of the federal government. Ironically, these plans for a few years have been costing the federal government more than original Medicare. So it's crazy. It's definitely something that you shake your head and you think, well, what's the best way to go? And honestly, the answer is that as far as any Medicare member is concerned, the right choice is a personal choice, and you are going to be weighing all of these different factors to determine what's best for you. So some of those factors are, what doctors can you use? Well, on original Medicare, over 96% of all healthcare providers in the country participate in original Medicare. So they take A and or B. So you don't have a network. Or you could say your network is 96% of all healthcare providers in the country, whatever is the easier way to think about it. But you do not need referrals. And there are also almost no prior authorizations, meaning if you and your doctor decide that there's a course of treatment, a procedure that you need to do, if it's covered by Medicare, which is known by that provider with the 5-digit codes that are used for Medicare billing, you and the doctor go ahead and do that procedure, and the doctor bills Medicare. So prior authorizations are a pretty big deal. You don't have those with original Medicare, and you don't have a network. You just see any healthcare provider anywhere in the country that accepts Medicare. On the Medicare Advantage side, these plans are network-based, and so whichever plan you choose, you will have either an HMO or PPO structure. Typically, there are a few other plan structures that are less common, but you'll want to stay within that network. If it's an HMO, you'll want to stay in the network because you won't have coverage if you go outside of it. PPOs will usually have a lower out-of-pocket cost if you stay in the network, and they'll still help if you go out of the network, but you'll pay more out of pocket. The other issues with these managed care plans are that often referrals are needed to see specialists or to go outside the network, and there are more prior authorization requirements on your care. So in other words, these are smaller coordinated plans where there is the ability for that plan to sort of have oversight on your healthcare use. So they're looking at what you and your doctor want to do and saying, I don't know, let's see, maybe ask again in a few weeks after you try these other things. So that is something to keep in mind with Medicare Advantage. The prior authorization threshold is higher, and it's something that studies have shown is usually the thing that people are most critical about on the Medicare Advantage side. And then how do costs compare? Well, we already mentioned that with original Medicare and a Medicare supplement, of course, you're still paying for the monthly cost of Part B, which doesn't change in either of these scenarios. And then you have a monthly premium for that Medigap or Medicare supplement plan. We talked about how those vary depending on where you live and all of those other factors. On the Medicare Advantage side, you see very low monthly premiums, and these days we see zero premium plans all the time. But then as you use your health care, you will have out-of-pocket costs. So you'll typically have a copay or coinsurance for whatever you do, and the amount depends on the plan and what that service is. And also it can depend on the provider if you go out of network. Now, all of those out-of-pocket costs, my copay here, my coinsurance there, my deductible, another copay, coinsurance, all of those are adding up to a maximum out-of-pocket amount for the year. And the top out-of-pocket is set by Medicare, but then these plans can compete with each other by having a lower maximum out-of-pocket, which is very appealing to consumers. But there's always a maximum out-of-pocket on those copays and coinsurance so that I know I'm not going to have runaway costs in excess of a certain number. All right, and prescription drug coverage. So we talked about how under original Medicare plus a supplement, it's a very a la carte setup. So we're choosing these different components and putting them together into this customized insurance arrangement. The Part D piece is separate. And then on the Advantage side, it is usually included with that Part C or Medicare Advantage plan. The additional benefits we mentioned, so you do not have dental coverage under original Medicare. There's no requirement to have it. You can opt to add a separate individual dental plan or not, or you can self-pay. And basic vision is not covered. Now, basic vision means that Medicare A and B and my supplement will not cover my glasses, my contacts, or my annual eye exam, but they absolutely will cover my medical vision needs. So if I'm seeing an ophthalmologist for eye irritation or some kind of damage to my eye, glaucoma, macular degeneration, whatever it is, my health needs of my eyes absolutely are covered by Medicare. Hearing is one of those other items that's not covered on the original Medicare side. Now, again, Advantage plans will typically include these additional benefits, but they will always have a maximum annual allowance, and they will often have copays or coinsurance associated with these benefits. And then there will also be contracted providers that you will need to use to access those additional benefits. So it is something where if you are looking at Medicare Advantage coverage and you're really focused on that dental, vision, and hearing, you really want to look at the fine print and evaluate the value or the benefit that you truly would get from that dental, vision, and hearing, because it can be a pretty significant trade-off if you lose access to a certain doctor or other healthcare provider that would no longer be in network. So it's an evaluation that each person would want to make. And then finally, how and when can you get each of these types of coverage? We find over and over again that this is one of the most misunderstood elements of these two choices. So on the left side, Medicare supplements or Medigap plans are only guaranteed, and this is in the majority of states, the vast majority of states, when you first start Medicare Part B. So that's a window of 6 months when you first start Medicare Part B, called the Medicare Supplement Open Enrollment. There are a handful of discrete circumstances where you could also be guaranteed this coverage. Those are called periods of guaranteed issue rights, and that could be leaving an employer plan, your plan goes away. There's other circumstances that are less common. So the main thing to understand is that this coverage is more private and it does not have an annual enrollment period in the majority of states. So if it is a type of coverage that you would want to have, you'll want to get it at the right time and then be very cautious about ending it, because it's not something that you can just wait for the next annual enrollment period and get. Medicare supplements are not part of the annual enrollment. You can apply for one at any time of year, but if you don't have your first 6 months of starting Medicare and you don't have one of those guaranteed issue rights I mentioned, your eligibility is determined by your current health status, pre-existing conditions, and medical history. And you might be rated up or decline for this coverage. So this is something that people typically don't understand. I'd be curious if anyone wants to put in the chat whether they knew that already or they thought Medicare supplements were part of open enrollment, or we call it open enrollment. It's really annual enrollment for Medicare. It's something that people just don't know. And it's something you should know if you have a Medicare supplement, because it's a very valuable piece of insurance and you would not want to walk away from it lightly. On the Medicare Advantage side, however, these plans are a part of the annual enrollment period. So they are available to everyone. They are never based on your current or past health status. Everyone in the same service area pays the same amount for that plan. And you can get one every year during the annual enrollment period. So a very different situation in terms of how easy or when you can get these two types of coverage. All right, so I'm just going to take a moment to see if I can tell whether or not we have any folks who have dropped a question in the chat. And I don't see any in the chat right now, so feel free to place a question there and I'll take a look again in a moment and we'll see if there are any questions related to anything we've touched on so far. All right, so I mentioned that we would talk about a couple of enrollment periods, and the first one is the initial enrollment period. So most people will have their initial enrollment period as their first opportunity to enroll in Medicare. This is going to be based for everyone on the month that you turn 65, and it's actually a 7-month window. And I'll use my birthday as the example. So my birthday is on October 10th. So my month I'm turning 65 is October. And that means I have all of July, August, and September to start applying for my Medicare. And it will actually begin on October 1st. Medicare parts always begin on the 1st of the month. So even though my birthday is the 10th, my Medicare would start on October 1st, and my first month that I can apply will be July, starting on July 1st. Now, my husband's birthday is October 1st. The first of the month is a birthday that pushes everything back a month. So if you have anyone in your life, or if you have a first of the month birthday, just know that their Medicare enrollment is the one, that's the one day of each month that's quirky. So my husband's month will actually be September here, and then he's going to have June, July, and August, because his Medicare benefits will begin on September 1st for his October 1st birthday. Most of the rest of us just look like mine. All the time we have people say, my birthday is August 23rd. So I'm going to start my process on May 23rd. And we say, no, your benefits will start on August 1st and you can start on May 1st. So just remember that everything you see here is based on a whole month. Okay. The next most common enrollment period, especially these days, a lot of folks will either work past 65 themselves, or they may be covered by a spouse's employer plan, and they will remain on that coverage after turning 65. So there tends to be a lot of confusion about who can and should apply for Medicare in those circumstances. So it all really comes down to the size of the employer who is providing that employer coverage, whether it's your employer or your partner or spouse's employer. If that employer has under 20 employees, even if you or your spouse are just going to keep on working for many more years, you will have to go ahead and start Medicare, because that coverage is not going to be what is called creditable for Medicare, and you can find yourself in 5 kinds of trouble if you don't go ahead and start your Medicare at age 65. So again, if the employer through whom you have employer coverage has fewer than 20 employees, 65 is the age where you will start Medicare. If the employer has over 20 employees, then you can postpone Medicare enrollment. So you or your spouse, whoever, can keep working and you stay on that coverage, and you can wait until you're ready for retirement and then go on Medicare at that time. So this is something that we will walk through with clients sort of one-on-one, because sometimes there are other circumstances that we'll want to talk about, such as difference in ages of spouses and how long might someone need to keep working for a spouse to remain covered before both are eligible for Medicare. Or sometimes we'll have older children who are still on that work coverage, and we'll talk through all of those considerations before anyone makes a decision about applying for Medicare or not. You want to think of it this way: if at 65 you or your spouse with the coverage has this larger employer, now you're in the driver's seat, because you could start Medicare and the work status can remain the same if it's financially beneficial. If it's more beneficial to remain on that employer coverage, then you have the right to do that, and you will not have issues with penalties or delayed enrollment or anything when you go to enroll in Medicare later on. This situation of folks who work past 65 is probably the most common type of new client that we work with. So we'll talk to people who will say, I'm turning 65, but I'm still working. We'll walk you through what you may or may not want to do. We'll walk you through the timing. And then we turn around and it's 2 or 3 years later and they're calling and saying, okay, we're retiring now. And we'll walk you through that next phase of the process. A couple of other items to note. COBRA is something that often comes up. If you are over 65, you cannot have COBRA coverage as primary insurance. Unfortunately, most HR folks don't know this, and the insurance companies that are available for this COBRA coverage are not typically going to notify you that they would not be the primary payer. If you're no longer working, you're on COBRA and you're 65, they'll take your premiums. You keep paying that premium, and if your healthcare use is less than what they're receiving, they're not going to notify you. But if something occurs and you have a major use of healthcare, they absolutely will let you know, hey, we saw that claim and we'll be happy to pay our part, usually 20% after Medicare A and B pay. And you say, but I don't have A and B. And they say, oh, sorry, you better hurry up and get that. And unfortunately, this claim is not going to be paid. So if you or anyone you know over 65 is thinking, oh, I'll just do COBRA and I'll figure out Medicare later, don't do that. COBRA is not a feasible option when you're over 65. Ending COBRA is also not a special enrollment period, so it doesn't really buy you what we would need to get you out of that situation. So COBRA, no good over 65 is the key idea. Okay, I'm going to pause here. I'm going to check the chat again. I don't see any chats. Let me see if anyone has their hand raised, if they wanted to speak a question based on anything that we've touched on so far. I see lots of familiar names here, but I don't see any hands raised. So we'll just jump on into our next section, which is talking about Medicare Part D. And as I said earlier, this tends to be the most confusing part of Medicare. It's structured in a way that is intended to protect the costs for coverage for the federal government, so for Medicare Part D itself, also for the private insurance companies that offer Part D plans. So there are all of these coverage stages that are in play that are designed to really manage use of prescriptions and make sure that no one is just filling something just because they have a refill available. You're filling it because you actually use the medication. So this whole Part D prescription drug program is set up in a way that is designed to manage that use. But the effect for the Medicare consumer is, I don't know what my prescriptions are going to cost the next time I go to the pharmacy, because it's a little bit variable throughout the year, and it can be very unsettling for Medicare consumers to not know what to expect. So In the past, there have been 4 stages of Part D coverage. So the good news for 2025 is that for the first time ever, there will be a cap on out-of-pocket costs. And in the process of adding that cap on out-of-pocket costs, Medicare has eliminated the coverage gap, the Part D coverage gap. This is what is commonly known as the donut hole. So I think anyone who's been in this country for the last decade and a half has heard someone talk about the Medicare donut hole. You see it on political ads during election cycles. And for many years, it was a really tough time when a Medicare consumer would reach the donut hole because their out-of-pocket costs would go way up. Over time, the donut hole has been whittled down to finally in 2025, it's completely gone. So that's the big news. But there are still now 3 coverage stages. And again, they can still be a little bit complicated for the average Medicare consumer to navigate. So let's talk about what those coverage stages are and how they work. So Medicare coverage stages always operate on a calendar year, even when an individual starts Medicare for a partial year. So people have birthdays all year. Mine's in October. If I start Medicare at 65, I'll have coverage from October 1st through December 31st, and then my coverage stages will start again on January 1st. So for my birthday in November and December, we don't get a lot for our deductible and so forth. It just is what it is. This makes it, I guess, a little bit easier for everyone to keep track of. So the first coverage stage is the deductible coverage stage. And in this coverage stage, the Medicare member will pay 100% of the cost of covered prescription drugs until that plan deductible is met. Now, there are some plans that have no deductible. In 2025, there will be very few, almost no plans that omit the deductible, that have high premiums and no deductible. And we'll talk about why. Some plans will not apply the deductible to the lower tiers of medication. So if I have a tier 1 medication and a tier 2 medication, I might go straight into paying copays and not have to meet my deductible because those medications are so inexpensive. The maximum deductible for all Medicare Part D in 2025 is $590. You will find that deductible in most plans next year. So the plans can make adjustments to that, but for the most part, it's going to be $590. So when you've met your deductible, you then will go into the initial coverage stage. Now, new this year, as I said, for the first time ever, we are going to have a true maximum annual out of pocket on the consumer spending. So when you're in this initial coverage stage, you have met your deductible or bypassed it because your drug cost is low, and you are just paying a copay, which will be a fixed monthly amount depending on the tier of the medication and your plan, or a coinsurance, which will be a percentage of the retail cost of what you're filling. You'll pay that copay or coinsurance until you have a true out-of-pocket cost of $2,000. So this $2,000 will include the deductible if I've had to meet that, and it will also include my copays and my coinsurance. It will not include my plan premium, and it will not include any costs that I have for medications that my plan doesn't cover. So often people will have found a great deal for a medication through an online service or, something in Canada, or they have a great GoodRx deal for something that they're filling. None of those costs will accrue towards this $2,000 out-of-pocket maximum. It will just be the medications that you fill through your actual Part D plan. This is, however, really exciting for a certain small percentage of people, but I think the way to look at it is that any one of us at any time could fall into that category of individuals who need an extremely expensive medication. So a couple of years ago, to give you an example and put some numbers to this, going into 2023, I had a handful of clients whose prescription costs, in one instance, with the best coverage that we could find, this individual was still going to have an out of pocket cost of over $12,000. This was back when there was no maximum out of pocket. So they were filling a very expensive medication that they had to take daily, and that was what their out of pocket cost was going to be for the year. So people who had those medications were experiencing amounts like that, and I've even seen higher, unfortunately. So that, while a small percentage of individuals on Medicare, it was typically medications that were, really life-saving significant medications, oral chemotherapy, oral immunotherapy, things that were really not an option. And so the impacted folks are really the reason for some of this very significant change that's occurring in Part D. Now, this annual out-of-pocket maximum of $2,000 is a result of the Inflation Reduction Act of 2022. That legislation included a big bundle of changes to Medicare Part D, some of which have already gone into place and some of which we're still incorporating in the next few years. This is one of those big changes, and it's been mentioned a few times in the current political discourse, that Medicare members will have a $2,000 maximum out of pocket. Now, I mentioned that that impacted a small number of people. The studies are showing that approximately 1.6 million Medicare members out of over 66 million Medicare members altogether, so 1.6, will save money based on this new out-of-pocket maximum. Of course, my client with the $12,000 medication, this is an enormous impact for someone like that. However, everyone else is probably going to be experiencing some changes in their coverage that will allow all of this to happen. And so those changes will include things like higher monthly premiums. I already mentioned that there will be more plans that have you meet that whole deductible. There will be more measures that control costs for the plans themselves. These are things like prior authorization requirements. So there may be medications that you filled in 2023 and 2024 where all you needed was the prescription, no prior authorization. Moving forward into 2025, you might now need prior authorization. All of these things that are happening are ways that these Medicare Part D plan providers, the insurance companies that contract with Medicare to provide this coverage, need to be able to continue to do so while all of a sudden capping the consumer's cost at $2,000. So there are a lot of accumulating impacts as a result of this. So the number of things that will be occurring, little changes that you'll see in your coverage that are making this happen. From that $2,000 annual out-of-pocket threshold, once you've met that, you are in technically the catastrophic coverage stage and you pay nothing. There's no cost sharing for your covered drugs. Now, again, covered is the key word because if you're filling something apart from your plan, you will still pay for that medication, but items filled through your plan will have no out-of-pocket costs. Now, one of the other impacts from the Inflation Reduction Act that goes into effect for 2025 is the prescription payment plan option that will be available from every Medicare Part D plan provider. So they are calling these M3P, so not to be confused with MP3, but M3P options, and every plan will have this option. So you can opt in at the beginning of the year, or you can opt in throughout the year if you need this. And what this is a program that will allow a Medicare consumer to fill a very expensive medication and to leave the pharmacy with that medication in hand, but to spread that cost over up to 12 months. so they can spread that cost over what remains of the calendar year upon filling that medication. Now, the requirements for participating in this are pretty stringent in the sense that the actual out-of-pocket cost for a 30-month supply must be $600 or greater. So this is only going to be something that will impact someone with that specific one medication that will have a $600 or more out-of-pocket cost. But there are no fees to use these services and there's no interest. So it does really help people who may be experiencing, in many cases, the full $2,000 out-of-pocket cost very early in the year. They would be eligible for this program and they'd be able to spread those costs over the rest of the year. So that's new and it should be helpful for several people. As you probably know, covered insulin, so not all insulin products are going to be covered on every plan, but covered insulin products are capped at $35 to the consumer. And now all Medicare Part for the last year as well, all vaccines that are recommended for adults are available at no out-of-pocket cost. And that's a big change because some of those have had pretty hefty out-of-pocket costs in the past. All right, this slide has a lot going on. So I'm just going to take a peek and look for any hands raised or any chats. I don't see any. Let's see. And I'm not sure. Sometimes the chat is not enabled for all participants. It probably is, but just want to make sure that if anyone has a question that they are either able to raise hand or unmute or place that question in the chat. As we are getting to the end here, so let's talk about the annual enrollment period and then we'll just fully open up to whatever questions you have. Okay, so let's get into what's going on this time of year every year. The Medicare annual enrollment period runs from October 15th through December 7th every year. Doesn't matter if those days are Sundays or holidays, these are the dates. And plan changes that are made or plan selections that are made during this enrollment period, using this enrollment period, will begin on January 1st. Now, this enrollment period only applies to people who are currently on Medicare, meaning they are on Medicare A and B and some other combination of plans. Very frequently, we will have people during this time of year who maybe have a birthday in December or a birthday in January or February, and they think, oh my gosh, I'm Medicare eligible soon. I have to do something because it's the annual enrollment period. It does not apply to people who are new to Medicare. You have your own enrollment period, either your initial enrollment period or you're working past 65. This one, there's only activity going on for people who are already on Medicare A and B and the other types of Medicare coverage that we've talked about that work with A and B. So the things that you hear and that you see, sort of the impression you're left with at this time of year is that now's the time to make a change and you have to do it. There's something you have to do. We tend to get all of our clients just kind of feeling panicky and saying, what do I need to do? I need to do something. I need to confirm that I want to keep my plans. Do I need to change my plan? Do I need to sign something, enroll in something, etc.? You get that message a lot. There's a lot of marketing, a lot of advertising that makes people feel like there are plans out there that cost nothing and they'll give me money back for what I pay for Part B. And if I'm spending anything on my Medicare, I must be doing something wrong. I better find out what these free things are and why everyone else has one. So that's one of the messages that people tend to get. And then you see in a lot of the marketing, all of these offers for hundreds or thousands of dollars in free things, whether it's groceries or rent and utilities, medical supplies. All of these things tend to really get people's attention this time of year, and it gives you the impression, I need to do something, I'm missing something. What is it I need to do? Well, the truth is that there is no action required during the annual enrollment period. If you have Medicare plans and you don't want to change them, you don't need to do anything. You can leave the whole thing alone and you will wake up on January 1st with the same coverage that you have right now. Of course, you do have to keep paying the plan premiums. And the other exception to this that we will be seeing a bit more going into 2025 is that you may have a plan that may be just leaving the market. So, with those increasing costs passed along to Medicare Part D providers, bringing that cost of the consumers out of pocket down to $2,000, the Medicare plans themselves, the Part D, but also the Advantage plans, because they have Part D in them, they're all tightening their belts. A lot of them have increasing costs. So instead of seeing your premiums come down, you're seeing them go up. And many of these large insurance companies will say, we can't offer 8 plans anymore. We're going to take it down to 3. So we're seeing some plans go away. And for those folks, they would need to take action during this time. But if your plan's going away, you will have been notified of that. Anyone else, you don't have to make any changes at this time. And then for the rest of that messaging, the everything should be free and where are my grocery gift cards and so forth. The truth is that if it sounds too good to be true, just like anything else in life, of course it probably is. So many of those features that I mentioned are elements of Medicare Advantage plans that are designed for people who have low income qualifications. So these are people who will either qualify for assistance from Medicare and or from their state Medicaid program. If plans with those benefits are offered in a market, the advertising can feature all of that, and it's going out to everyone in that market, but you don't know until you call and inquire about it that you don't have the economic situation that qualifies you for all those goodies. So I don't think it's intended to be a bait and switch, but that's the impact. People think there's something out there that's free and then some, only to find out that those plans that offer those really extreme extras generally are for people who qualify based on a very low income. So, changes that you actually can make if you'd like to during this enrollment period are that if you have a Medicare Advantage plan and you'd like to change to a different one, this is the time of year where you can do that. If you're on original Medicare, either with or without a Medicare supplement, and you'd like to enroll in an Advantage plan, you can do that during this enrollment period. If you have a Medicare Advantage plan and you'd like to go back to Medicare A and B, you can do that this time of year, disenroll from Medicare Advantage. However, keep in mind that securing a Medicare supplement policy will typically be tied to your health status. And so that would be something to be careful of to make sure that you could get that if you wanted that. If you have a standalone prescription drug plan and you would like to change that or need to change that, you can do that now. Or if you need to get a Part D plan or leave a Part D plan, both of those are things that you can do at this time. All right, so I'll leave this slide up for just a second. These are some of our resources, ways that you can connect with us. We do also have a fantastic series of really short videos, um, um, simple videos that explain many of the things that I've talked about today, but in short little bites. All of that is found on our mpgroup.org website. So that's under MP University, and we just launched that within the last couple of weeks. So check that out if you'd like to take a look at additional resources. And I am looking, I see a question in the chat about how do I get Medicare to equate my current health program with my doctors? Is that an option? Paying more and adding. Okay, so I think what we're asking is how can we make a Medicare coverage selections that are equivalent to a current health plan that you like? And to keep your current doctors, typically you would have Medicare A and B and a Medicare supplement, because again, 96% of all healthcare providers in the country will accept original Medicare A and B. And then it doesn't matter who your supplement provider is. As the secondary payer, they have no say in what doctors you can use. So we would do that plus a separate drug plan and potentially a separate dental, vision, something like that. But that is the way to have the most doctors covered. There will be some situations where you may have a concierge doctor who is not going to be covered, but doctors that don't take insurance, where they are just out-of-pocket costs to you, are still going to be out-of-pocket costs to you on Medicare. So that's usually how that will equate. Any other questions? I'm looking for hands raised or any more input in the chat. Okay, and so I have a question. If one has a current Medigap plan, then it may be difficult, if not impossible, to change to another Medigap plan. In most of the states, right around here, where VLP is located, that is true. Maryland did pass a law that went into effect this last year that will be a slight twist to that. So if you're a Maryland resident, there's a little bit more flexibility, but Virginia, DC, Pennsylvania, Delaware, that is true that changing your Medigap plan to one from a different company does involve that approval based on your health status. So that's the medical underwriting process. Let's see. Okay, looks like I have this question came in a second time, but I did answer that about getting the Medicare equivalent to a current plan that you're happy with. But of course, please feel free to reach out and set up a time where we can talk to you directly about your unique situation, and we'll ask all of the important questions to make sure that we know all of the pieces to your circumstances and make recommendations according to that.
All right, well, thank you so much, Emily. So that was a lot of very detailed and really helpful information. So we appreciate you taking the time to present today.